welcome. My name is Beth Boudreau. I'm responsible for professional education at Navident. Our program tonight is Optimizing Ergonomics with Dynamic Navigation and Microscope Dentistry. Our speaker is Dr. Bobby Nadeau. Our moderator tonight is Dr. Ken Sirota. So I will encourage everyone to please type in your questions into the chat box, and Ken will be keeping an eye on that. We also have some time built in at the end of the program so that we can get to all your questions. And I'll also give you the instructions to get your CE credit at that time. So without further ado, our moderator, Dr. Ken Sirota, obtained his Master's of Medical Sciences degree and certification in endodontics from the Harvard Forsyth School of Dental Medicine. He's always been fascinated by technology, and along with Fred Barnett and Joe Dogan, he found the first online endodontic forum called Roots in 2000. He founded the Facebook forum Nexus in 2015, and that has a focus on transdisciplinary dentistry. So without further ado, Dr. Sirota, the screen is all yours.
Thanks, Beth. I had the opportunity to get to know Bobby in his last year of the postdoctoral program in endo at U of T. He initially graduated from Dalhousie with his DDS. That's in Halifax, Nova Scotia. And as I say, he recently completed his final year. He's now practicing in Kingston, Ontario. Bobby was always a very focused and disciplined clinician during his training. And he has sort of morphed that into an interest in dynamic navigation, most things minimally invasive. That relates to ergonomics and microscopic dentistry. Very focused on minimally invasive, I say, in terms of restoratively driven endodontics and in clinical decision making, which in and of itself is probably increasingly more important in endodontics than sort of the staples of instrumentation, irrigation, and obturation. So without further ado, I would like to introduce Dr. Nadeau. Bobby, the floor and the video is yours.
Thank you, Ken. It's very nice to be here tonight. I hope everyone is doing okay at home during these very strange times. So today, like Beth and Ken said, I'd like to discuss an area that I find most interesting, which is ergonomics with dynamic navigation and microscope dentistry. I'm excited to share some of the conclusions that I've come to for myself for this topic. It's a forever changing field right now. So these conclusions are not absolute, but merely a starting point for other clinicians to add to. And yes, we need other clinicians to chime in to advance this field of dynamic navigation in dentistry, particularly in endodontics. So like Ken said, for those of you who don't know, I am currently working as an associate in private practice limited to endodontics, and I'm located in Kingston, Ontario in Canada. So the outline for today, I'll be starting by discussing some of the foundational principles of the surgical operating microscope dentistry in endodontics. I'll review some of the principles of dynamic navigation, more so using Navident, and I'll discuss some key points that are needed to integrate dynamic navigation with the operating microscope. I will touch on the main application of dynamic navigation in endodontics, which in my view is for non-surgical access cavities. I'll also touch on other applications in endo for dynamic navigation. Then I will discuss some of the tips to optimize the ergonomics of Navident and microscope dentistry. And I'll wrap things up with a new surgical application that Navident has that is applicable for endo. All right, so for me, my journey started in 2016 with microscope dentistry. Under the leadership of Dr. Basrani at the University of Toronto, I was exposed to the operating microscope, and one of my dear mentors, Dr. Shimon Freeman, really laid down the foundational principles for me for the use of the microscope in endo. I also want to acknowledge some amazing clinicians that have had a tremendous impact on me that has led me to pursue a particular interest in microscope ergonomics and dynamic navigation. Dr. Gary Carr really was the first clinician to popularize the surgical operating microscope in endodontics and dentistry. His pioneer work in multiple facets of endodontics, including ergonomics and efficiency when using the operating microscope, has had a huge influence on me personally. Carlos and Ken also had a big impact on myself as well. Carlos is renowned for his optimal ergonomics, efficiency, and teamwork approach for both non-surgical and endo, but especially surgical endodontics using a microscope. Carlos is the expert, really, I feel like, in efficiency, especially during endo surgery. Ken really goes into details about how to incorporate the microscope in your dental practice. I highly recommend the viewers who are interested in learning everything really that there is to know to incorporate the surgical operating microscope into their practice or to improve their microscope skills to check out Ken's website, quantumergonomics.com. I was introduced to dynamic navigation really by Dr. Charles Maupin. He's known to be one of the first endodontists to really document and publish about the potential applications of dynamic navigation in endodontics. All right, so let's first start by reviewing some foundational principles with the surgical operating microscope in dentistry. The introduction of the microscope into dentistry in the last 20 years, particularly in endo, has really revolutionized how endodontics is practiced worldwide. The operating microscope gained quite a rapid acceptance within the endodontic community, at least in the last 10 years, 10, 15 years, and is now a very important tool in our tool bag. And then it's not only for endodontics, but we're starting to see also a specific interest in periodontics and restorative dentistry as well. In 1999, Gary Carr, introduced the operating microscope that had Galilean optics, and that was really ergonomically configured for dentistry, with several advantages that allowed for the use of the microscope for nearly all endodontic procedures as well as restorative procedures. So I strongly recommend anyone interested in learning everything that needs to be learned, really, when it comes to the dental surgical microscope, to read this article here published in 2010 by Dr. Carr and Dr. Mergo. The operating microscope offers obviously many advantages. The first one, the obvious one, is the high magnification that comes with the scope, but also the high illumination, which is very important. Any device that enhances or improves a clinician's resolving power of the eye is extremely beneficial in producing precision dentistry. Restorative dentists, periodontists, endodontists routinely perform procedures that require resolution that is well beyond the 0.2 millimeter limit of the human sight. And what I mean by that is that most people, like you and I, who view 2 points closer than 0.2 millimeter will only see 1 point. So the magnification is extremely important. And also by increasing light levels, one can increase apparent resolution as well, which is the ability to distinguish two objects close to each other as separate and distinct. So you really cannot see what you cannot see, whether it's prosthetic margin diagnosis, clinical diagnosis of cracks, recurrent caries under restoration, or micro incisions and suturing using fine sutures. And the list of the benefits of high magnification and illumination is indeed very long. The second advantage that the microscope offers is improved posture. We all know someone in the dental field, whether it's a clinician or a dental assistant, that has chronic neck, shoulder, or back problems. And so proper posture, I think, is critical in achieving longevity in our field of dentistry. And so an understanding of efficient workflow and proper posture using the scope entails knowing the basics of ergonomic motion. And so ergonomic motion is usually divided into 5 classes of motion. Class 1 motion is the movement of the fingers only. Class 2 motions is the movement at the level of the wrist. Class 3 motion is movement originating from the elbow. Class 4 is movement originating from the shoulder. And Class 5 motion is movement that involves twisting or bending at the waist. There should really be no Class 4 or 5 motions when it comes to efficiency and proper posture. And so ideally, for optimal ergonomics, all motion should be limited to Class 1 motion, Class 2, and Class 3 motion. The operator should adjust the seating position so that the hips are at 90 degrees to the floor, the knees are at 90 degrees to the hips, and the forearms are at 90 degrees to the upper arms. The operator's forearms should lie comfortably also on the armrest, on the operator's chair, and the feet should be placed flat on the floor. The back also should be in a neutral position, and it should be erect and perpendicular to the floor, and the natural lordosis in the back should be supported by the lumbar support of the chair as much as possible. The eyepiece can be inclined so that the head and neck are held at an angle that can be comfortably sustained throughout the procedure. And so the neck and back are completely at rest in this particular position. So that's what I'm striving for. I'm trying to constantly work on my own microscope ergonomics. I certainly don't consider myself an expert in this field, but I am striving to reach that level one day. The third advantage of the microscope, like I said, is efficiency. For our purpose, efficiency entails accomplishing the procedure with the least wasted movements. And the fourth advantage that the microscope allows for is obviously photo and video documentation. I found that this can facilitate case presentations with our patients, but also helps with discussing cases with colleagues. It can also become crucial for medical legal issues as well. So these are compelling reasons why the microscope should be an integral part of pretty much any dental practice. And then Karen Mergel writes, the skillful use of an operating microscope entails its use for the entire procedure from start to finish. And for me, that also means during dynamic navigation, as we'll see. There are many restorative dentists that now use a microscope for most, if not all, facets of restorative dentistry. For the general dentist viewers here tonight, I strongly recommend you look into the incorporation of the microscope into your practices. This is Dr. David Clark, who is, in my opinion, one of the best restorative dentists in the world. He incorporated the microscope in his practice maybe 20 plus years ago, not more than that. This is one of the many articles that he has on the benefits of the microscope for general dentists. So if you have time, check it out. And so in restorative dentistry, the benefits of the microscope include, and this is from another article, it includes better margin preparation, better detection of cracks and fractures, among many other obvious benefits. The microscope is also gaining a lot of interest in the periodontal community for its benefit as well, and it's for benefits for things like minimally invasive surgeries that will speed up healing and recovery, allowing for microsurgical approaches using microblades and extra fine sutures to again enhance wound healing, better connective tissues as well, better connective tissue grafts, improving the visualization of implant sites, facilitating sinus lift procedures, and things like fine dissection of important anatomical structures during implant procedures, and the list goes on and on. So much so that it is being used for implant therapy as well. Many periodontists believe that the dental surgical microscopes significantly enhance the field of view during implant placement procedures. It increases the precision with which implants are placed, minimizes trauma, and reduces recovery time, not to mention the benefits, obviously, on posture and longevity. Even in oral surgery, it is reported to have important benefits, especially for management of impacted teeth. So as Carr writes, the advantages of the use of the microscope is in providing precision care will carry over into restorative dentistry and will eventually become a universal approach for all phases of dentistry. And I think he is absolutely right. I agree with him. All right, moving on now for maybe some of the viewers that may not be familiar with how dynamic navigation works, especially dynamic navigation with Navident. Let's review some of the principles of dynamic navigation. In my practice, I use Navident system from Clarinet, and briefly, the way Navident works is pretty much like any dynamic navigation system works, is that a CBCT scan of the patient's jaw and teeth is taken and is imported into the software. In the case of Navident, the software is run within the laptop that comes with the system, which is mounted onto a small movable assembly cart. Stereoscopic cameras are also mounted onto the cart assembly. And these cameras track the position of specific markers. And there's a marker which is secured onto the dental handpiece. This marker tracks the position of the burr or drill used during the procedure in three-dimensional space. And there's a marker secured on the patient's jaw that tracks the position of the area of the jaw receiving treatment, whether an implant site or a tooth or an apical surgery site. And so this site is also tracked in three-dimensional space. The jaw tag can be secured using a small tray in polyvinyl siloxane PVS material. And what dynamic navigation allows, at least in my practice, is as we'll see, is the planning of an access cavity in endo. Although the use for Navident is officially for increasing the accuracy of dental implant placement, off-label use includes helping in accuracy of endodontic accesses. So an access path can be planned before the patient even sits in the chair for treatment. And this allows for a perfect straight line access with maximum dentin conservation for strength and longevity of our treatment in endo. Once the access is planned, the system tracks the position of the burr in three-dimensional space and overlays it over the virtual CBCT scan of the patient. By looking here at the bottom left target area, the clinician can maintain the pre-planned access path. And so the proper planned angulation and depth of access cavity can be achieved. And so this particular type of navigation is called planned navigation because you're pre-planning an access path and you navigate it using the target. But there is also another type of navigation called unplanned navigation, where all the clinician sees is the position of the burr superimposed onto the virtual CBCT scan. So in this case, no access is pre-planned, so therefore there's no target to follow. This can be used in cases where absolute accuracy is not necessarily needed, but the clinician still wants that extra little bit of feedback. We will also see later other potential applications for Navident in endodontics. Right, let's discuss some of the key points needed to integrate dynamic navigation with the use of the microscope. Perhaps, I think, the most critical factor that any dynamic navigation system must have in order to be able to be integrated with the microscope is the ability to place the system's stereoscopic cameras in different positions. Other dynamic navigation system, as far as I know, and maybe I may be mistaken here, involves the somewhat mandatory positioning of the cameras, which happens to be often bulky, more or less right above the patient's head. And this immediately prevents the use of the microscope since obviously the microscope will be in the way of the cameras. preventing the cameras to pick up the fiducial markers attached to the handpiece into the patient's jaw. So the versatility of Navident allows for the positioning of the cameras, which are much smaller in size usually, to be lower and over the patient's chest, or even positioned to the side. And so the drill tag and jaw tag can still be tracked during the procedure without being hidden from the microscope. And so this is, I think, the first important key for the integration of dynamic navigation system with the microscope. Other key points involved in microscope ergonomics with Navident is the location of the jaw tag on the patient's jaw. Given that the clinician sits at 12 o'clock on the mandible when working on a posterior tooth, the jaw tag tray should be placed on the anterior portion of the dentition, with the jaw tag itself projecting anteriorly to the patient's chin. And so what this does is it allows for the handpiece and mirror to be used without blocking the jaw tag from the camera. And if working on an anterior tooth, the jaw tag tray is placed in the posterior region, preferably on the side of the mirror hand. But the jaw tag itself has to project to the anterior area again, away from the mirror hand and handpiece. This is done by pre-bending the stainless steel wire that attaches the jaw tag itself to the tray. And by the way, here I like to wrap some silicone tape around the wire. I found that it appears to be more comfortable for the patients in areas where the wire may be touching the lips. In the maxilla, same principles apply. The jaw tag should project in the anterior area when working on a posterior tooth. Same thing when working on an anterior tooth. It is secured in the posterior area, preferably on the mirror hand side, but is projected anteriorly over the patient's nose. And then the rubber dam can be placed over the tag before access cavity begins, or alternatively, many teeth can be isolated within the rubber dam isolation from the beginning, and the jaw tag tray can be placed over the rubber dam from the beginning. Another important point about jaw tag placement that I want to talk about has to do with the microscope light. So here's our jaw tag in this case. And so having the jaw tag fully or even partially located within the circle of light of the microscope can cause light reflection and prevent the cameras from capturing the black and white patterns on the marker. Therefore, the jaw tag should be placed such that it is outside the circle of light of the microscope. All right. So perhaps the main use for dynamic navigation in endodontics is to help finding canals. It can also provide guidance to reduce the procedural time, to help reduce the clinician's anxiety and stress, especially in cases of calcified canals. Or it can be used in cases that may not be classified as, calcified or extremely challenging in terms of access cavity, but just where a bit of guidance to provide accurate access to conserve as much dentin is wanted. Before I get into it, with any dynamic navigation system in dentistry currently available, as far as I know, we have to understand that the clinician has to look at a laptop screen or a monitor interface to obtain the visual feedback required for navigation. So positioning of the screen can become a problem when using the microscope at the same time. So my first solution was to try to improve ergonomics by mounting a field monitor onto my microscope and to connect it to the Navident laptop with HDMI to really mirror the display of the screen into my monitor. Therefore, what that will allow would allow for me to see the screen with a small movement of the eyes. I could go back and forth from the microscope binoculars to the field monitor to obtain the visual feedback during navigation. So this patient presented to me with a lower central incisor with pulp necrosis and apical periodontitis. These, in my view, these lower anteriors are so, they're obviously so tiny mesiodistally to begin with. I strongly think it's absolutely crucial to maintain as much dentin integrity in these cases, so that the chances of achieving long-term asymptomatic and functional retention in a happy patient are as high as possible. So in this case, we decided to take a CBCT and do a guided access cavity using Navident. So this is us here during access cavity using Navident. You can see here the field monitor mounted on my microscope, and you can see the position of the cameras, the stereoscopic cameras to the side, allowing an unobstructed view to the markers. And I want you to take a look here at my eyes, more or less going back and forth from the microscope to the field monitor. I'll just let it play. You can kind of take a look. Kind of shows us a little bit what I'm doing here with the field monitor. And I'll just show another view here. Here's another view. The position of the jaw tag, again, like I mentioned, projected anteriorly away from my hands and my assistant suction tip. You got the cameras positioned to the side. And you can even see the laptop here, a screen, which I'm actually not looking at, like I said, because it's being mirrored on my field monitor, my external field monitor that I mounted. And then finished the access and evaluate it and see if we can pick up a file. And the file drops right in. I'm going to show what the screen actually looked like, what is actually shown on my field monitor, what I'm looking at for dynamic navigation feedback. So that's exactly what's being on the field on the external monitor during access cavity drilling. In this case, like I said, I use the unplanned navigation mode where the position of the burr is shown only without the actual target interface. So in this case, everything was kept conservative as much as possible, which like I said, I believe is crucial in these small lower incisors. I think it's actually crucial for all teeth, in my views. Now this case wasn't necessarily calcified, although dynamic navigation can provide maximal dentin conservation in a case such as this one. Perhaps the greatest potential it has in endodontics has to do with access cavities in calcified cases. So I'm going to go on a little tangent here for the next few minutes because I think it's very important. And then we'll come back to microscope ergonomics. This is a pretty clever study, which is currently in press in the Journal of Endodontics by Samir. And very good job. Him and his colleagues looked at the three-dimensional accuracy of dynamic navigation using Navident in locating calcified canals. They looked at 84 3D printed teeth replicas with a total of 138 canals. The canal depth ranged from 9.5 millimeter to 21 millimeter, which would be considered quite calcified. And this is the first study, as far as I know, to look at conservative access cavities using high-speed burr and using dynamic navigation. Like I said, at least that I know of. They evaluated the accuracy of the access cavity prepared, which is shown in red, as compared to the planned access cavity, which is shown in yellow. They evaluated these 5 parameters using post-operative access, post-access CBCT scans. So they evaluated the entry point difference in 2 dimensions, which is the number 1 shown on the screen on the image. Number 2 refers to the apical horizontal deviation difference in 2 dimensions. Number 3 on the image is the vertical deviation in 2 dimensions between the prepared cavity and the planned one. Number 4 is the apical deviation difference in 3 dimensions. And number 5 is the angular deviation between planned and prepared access cavity in 3 dimensions. They found that the total mean time of the access cavity procedure was just under a minute. And that includes quite calcified canals. The mean 2-dimension entry point deviation from the planned cavity to the prepared access cavity at the coronal level of the preparation was 1.1 millimeter. The mean horizontal deviation difference in 2 dimensions at the apical portion of the preparation was 0.9 millimeter. The mean 2-dimension vertical deviation at the apical portion of the preparation was 1 millimeter. And the mean 3-dimensional deviation at the apical portion of the prep was 1.3 millimeter. And finally, the mean 3-dimensional angular deviation between the planned and prepared access cavities was 1.7 degrees. This is an example here of a conservative access planned and executed in a severely calcified canal in one of the tooth replica that they had. So I think overall quite a clever study. Hopefully it is, it's the first of many more studies, including clinical studies, that will show the great potential of dynamic navigation in endodontics. But focusing on dentin conservation is not new in endo. Clark and Cowdemy and many other amazing endodontists and clinicians that I can call my mentors have been talking about dentin conservation and practicing dentin conservation principles for many, many years. So I'm really not talking about anything new here. These are the guys that are the true pioneers. They propose that PCD or the pericervical dentin plays a crucial role in transferring occlusal forces along the root, and that maintaining intact PCD is arguably the single most important factor in achieving long-term retention of endodontically treated teeth. Pericervical dentin refers to the dentin located about 4 to 6 millimeter above and below the level of the crest of bone. This book, Best Practices in Endodontics, is an amazing book by Rick Schwartz and many other extremely talented clinicians that I highly recommend if you're interested in reading more into this. One thing, though, is that the use of round burrs should be totally contraindicated for access cavities because, as shown by these blue arrows here, they promote gouging, they promote ledging, they promote inverse funneling, unnecessary dentin removal, and they can even promote eventually perforations. So here's the EndoGuide burr, just right beside its corresponding round burr, which is the number 2 round burr. It has a much smaller tip, and this tip has as the smallest portion at the tip of the burr, right? So the cut near the PCD is kept as small as possible. This burr is quite nice, actually, to use with Navident, both for slow speed or high speed. Here are some examples of access cavities using EndoGuide burr, trying to be conservative, trying to maintain as much dentin as possible, where pericervical dentin mostly, or the PCD is maintained as much as possible to hopefully get long-term longevity out of these teeth and maintain a happy patient. Now, I should say that these particular cases I'm showing here were not done using Navident, but I believe that they certainly would have been done even more conservatively and with better efficiency with the use of dynamic navigation. Now, in terms of evidence-based dentistry and literature, when it comes to making clinical decisions for our interventions, we rely on randomized controlled trials as our best evidence. Fortunately, we have very few of those in endodontics that help us decide if subscribing to dentin conservation principles is the right thing to do for our patients. But if we look at the next best thing available in our pyramid of evidence, which are observational studies and cohort studies, we can perhaps find some answer there. So let's apply a few criteria first. Let's try to find fairly recent studies with acceptable sample size, with medium to long-term follow-up times, which is what our patients really want from our treatment. And let's look at patient-centered outcomes, which in other words is basically, is the tooth still there at the follow-up? Can the patient chew on it, right? And if not, what caused, if the tooth's not there at the follow-up, what caused the tooth to be extracted? And well, it becomes quite clear, study after study really suggests that causes of extraction of endodontically treated teeth overwhelmingly involve structural failures, restorative failures, recurrent caries, periodontal failure, with failures of true endodontic origin, which mean pain of endodontic origin or persistent or increased apical radiographic findings, way at the bottom of the list. And so, yet, it seems like instead of focusing on what seems to be the most important factors to achieve patient-centered outcomes, such as conserving as much dentin to hopefully prevent structural failures and restoring the tooth immediately at the time of obturation, it seems that most of the focus in endo is about irrigation and disinfection, despite failures of true endodontic origin occurring much less frequently as a cause of extraction for the endo-treated tooth. But that's really another story that would require its own webinar. I just wanted to give a bit of a background as to why I think maximal dentin conservation is so important and how dynamic navigation systems such as Navident have this tremendous potential to allow the clinician to provide treatment for maximal dentin conservation with less stress and maximal efficiency. All right, going back to our ergonomics, after a few cases using this field monitor that I just showed, it became apparent to me that some improvement could be made with this setup. Like I said, that had mostly to do with the field monitor. You see, the type of microscope we use in dentistry creates a parallel optics that allows the clinician's eyes to focus at infinity, and that is key. Because infinity focus is similar to viewing an object position way far in the distance. And this allows for relaxed internal and external rectus muscles of our eyes. When the object being viewed is too close, this can create strain in these rectus muscles of our eyes. And for some people, this may happen if a field monitor, such as the one I mounted, is mounted too close to the eyepieces of the microscope. And so looking back and forth into the eyepieces and at the field monitor may lead to eye fatigue. Infinity focus is similar to viewing, like I said, an object position far in the distance. And so this allows for relaxed rectus muscles of the eyes and low strain. And so some say that to have relaxed eye muscles and to decrease fatigue, the object should be positioned at least 14 inches away from the eyes. The other factor with the field monitor had to do with the focal length of the human eye, which depending on age can be as low as 15 millimeter. Therefore, what that means is moving back and forth from an infinity focus in the microscope binoculars to focusing on the external field monitor, which may be positioned too close to the binoculars, can lead to eye strain within the lenses of the eye itself. So something, I think, had to be done to decrease eye strain and eye fatigue with my setup. So for me, the solution had to do with trying to get a new setup. Here's my microscope. I removed the external field monitor I had mounted on it. Here's our Navident camera and the card positioned to the side of the patient's chair as usual. Notice no more laptop on the card assembly because we will see we won't need it anymore. The laptop can be placed out of the way on the counter. And here's the key. The Navident laptop is connected through HDMI to an external TV monitor mounted on the wall. Now, instead of looking at a field monitor, I can look at a strategically positioned TV monitor, which allows my eyes to focus more at distance, which is similar to an infinity focus when looking down into the microscope binoculars, which puts almost no strain onto the eyes and decreases fatigue quite significantly, I found. So I put this video together to show a few things. I want to show this new setup. I also want to show how effectively one can use Navident with the microscope. Now, this here is using 3D printed model, a 3D printed TrueJump model, but the efficiency can be transferred to a real patient quite easily. So let's start and see. So like I said, the first step is to load the tray with PVS material. This can be, again, efficiently done under the microscope. Now here I don't have an assistant, but I would give that to the assistant to minimize my class 4 and 5 motion. Trying to keep it on class 1, 2, and 3 motion. We'll place the jaw tag. Let it set. We use fast set PVS material. It sets with the warmth of the patient's mouth within 30 seconds to a minute. Now we can calibrate our tracer. And now I'm looking at the screen. This is what I'm seeing on the TV monitor, and that's what the screen is positioned far in the distance on the wall. And so I can go back and forth between the scope and the screen with very minimal eye strain. And now we're going to be ready to do our tracing to register our patients. I think one of the advantages for me of doing the tracing under the microscope is to make sure to maintain that ball tip onto the teeth. And I've had this process. I felt like this process was much more efficient than having less magnification. Again, here I can look back and forth from the TV monitor to the microscope view. You can see here my model is getting a little bit beat up from all the procedures or the practicing I've done on it over the last year or so. So we can finish our tracing procedure here. And then we can do the same thing. We do our accuracy check under the microscope, making sure that where the ball tip is exactly where it is onto the software interface. Once we know our accuracy is confirmed, then we can move on to the next step. Again, with an assistant here, it'd be much easier. With endo, we like to use our rubber dam. It'll be even more important now to try to prevent aerosols. I believe this should be the first mandatory tool to prevent aerosols with the coronavirus to help protecting ourselves, our assistants, and our patients. So that rubber dam can be placed under the microscope, making sure that the jaw tag is not being disturbed. And that's extremely important because obviously if the jaw tag is being disturbed, then you have to start again. You want to make sure that everything stays as accurate as possible. So once the rubber dam is placed, we always want to go back to redo an accuracy check on the tooth that is isolated. Doing an accuracy check here again. So here the cool thing is here actually I was going to get ready to calibrate my my handpiece, my drill, but I wasn't happy with the planned access I had. And so with a wireless mouse, I can actually go and change that. That's a huge advantage of dynamic navigation as compared to static guides. Static guide, you get what you get. You have to either use it, commit to it, or you throw it away. If there's any changes in treatment plan that needs to happen during treatment, it's as easy as a few clicks with dynamic navigation. Huge advantage as compared to a static guide. So now we're going to calibrate the axis of our high-speed handpiece. Then we're going to place our burr, endo guide burr here in this case. Love these burrs. again, having an assistant here would increase efficiency. Calibrate the tip, making sure that it's nice and perpendicular to the surface of the calibrating tool. We're going to do our accuracy check with our tip. And then we'll start our drilling procedure. So this is what is showing again on the monitor. Trying to maintain a good posture. Now here I'm not using water, but obviously there would be water here in a real patient case. And we're going to reach our depth. And then once it's reached, put the handpiece down, take a file, and that's, you know, when that happens, is the best feeling ever. The file drops right in. And, you know, it's like I said, it's a great feeling. So putting this new ergonomic setup to use in a surgical case, actually. But first, before we look at, I want to discuss, like I said, most applications for Navident and other dynamic navigation systems involve axis drilling, whether for an osteotomy or to place an implant or for an endodontic access cavity. But there's a new application with Navident which involves planning a cutting plane and navigating it. This video here shows the planning of a cut plane for a root end resection during apical surgery. The location of the cut, as well as its angulation, can be planned. And so what that does is it can help to ensure cutting the roots at 90 degrees, which is what we want to do in apical surgery, and positioning the resection, you know, at 3 millimeters from the apex, as what studies seem to show that's the location of a root end resection. So this patient here presented to me with a lower anterior that was endodontically treated 5 years ago and retreated a couple years ago, but the sinus tract was persistent. So the tooth actually had no probing and mobility was normal. So we decided to take a cone beam and treat the case with an apical surgery. So we took a cone beam. You can see the size of the apical finding here on the cone beam. We planned a root end resection, cut using the new saw cut function on Navident, and we tried to position it in the right position and angulation as much as I could. And once I'm happy with it, in this case I used the PB1 blade sonic tip from LC Ultrasonic down in Brazil with Navident to complete the resection. So you can see the ultrasonic tip superimposed onto the scan, moving virtually as I move it clinically. The planned cut appears in green, and so this was used in conjunction with the microscope for the whole procedure with the setup that I just discussed with the TV monitor on the wall, as I just discussed previously. And there was a case. You can see also the benefit of high magnification and illumination that the microscope provides. I believe these were 6.0 or maybe even 7.0 sutures placed under the microscope. And so this is also a good example of the benefit that the microscope provides for photo documentation. So what does the future hold for dynamic navigation in endo? As protocols catered to endodontics emerge, many believe that dynamic navigation will perhaps be part of the standard of care in 3 to 5 years or so. So there's though still a lot to be learned in endo with this new technology. I currently learn something new with each case that I do with it. One thing though that I strongly believe is that any new technology should not disrupt the workflow of the endodontic practice. which is why a technology that allows for the concomitant use of the microscope is key in my view. And like I said, we need more clinicians and endodontists to use dynamic navigation so we can all learn from one another. I'll end with this. What if we could project the Navident laptop screen to within the microscope binocular view to provide augmented reality or image injection or even head-up display type principles? That way, the whole Navident procedure could be done looking into the microscope 100% of the time. No more looking at a screen. Well, this can be done right now today. Here's a video, very quick video of a prototype module allowing augmented reality with Navident. This is exactly what you see here when looking in the scope with this prototype. So here's a sneak peek into the future of optimal ergonomics with microscope dentistry. I want to thank everyone for listening. More to come in the future. Stay tuned, and God bless us all. Thank you very much.
Thank you so much. That was really informative. Great presentation. Appreciate it. We have a lot of good questions. We have some time for Q&A, so Ken, if you can join us and take some of the questions and see if we can moderate them, that would be great.
Okay. I assume people can hear.
Yes.
Okay. So let's go back a bit. Nishan, with regard to Moravision, Daron, who's the CEO, and Jason, who's the global VP, have been in touch with Dane Carlson of Seiler, and the integration or the potential integration of Moravision and the system is under discussion. Gergely, I think I understand what you're saying, but the bottom line is the light on the actual cart doesn't need to be on, and the effect of you're talking about the monitor on the wall. The monitor on the cart doesn't make a difference, and the light off doesn't you don't bleach out anything that you're looking at. Yeah, that's right. He's using the wall monitor, not the monitor in the cart. That's Bobby's perspective. That's actually not a bad thing to do at all because it blows it up. But the new Navident system has Lenovo and MacBook Pros, I think. And so the quality of the Retinal 4K on a MacBook Pro and the Lenovo screen is pretty neat, plus a touch screen. So I don't think that becomes an issue of lifting your eyes away. It also depends on where you locate the monitor, how close you are to the microscope oculars, so that you don't get light strain. Sylvia, you asked smallest FOV. I guess 4x4, 4x5, something along those lines would be reasonable. Depends on the systems, the new Carestreams, the 8100, 9600, and the new Merida all fit the bill in terms of using small field of view. Yeah, and the light doesn't have to be on. And that's pretty much it. I mean, the perio has been well documented, as was indicated in on the website, and there's more coming out. There's been a study that was just done recently using Typodont in Virginia, comparing endodontic access, in this case, using what's called EvaluNav, which is the confirmatory software that combines path and placement, that shows that the ability to use the avatar drill and the effectiveness is that you literally have very little divergence with respect to both point of entry and apical deviation, which in endo is crucial. And as far as Moravision goes, I would think if Bobby's using it on the screen, but he can certainly answer that question.
Yes. Sorry, Ken. Do you want to answer the question about Moravision?
Yeah, I mean, I know they're working on it with the Seiler rep, but your perspective would be probably more relevant. Right.
So I haven't tried it with the Moravision. I've only tried Moravision in the exhibitor hall at a conference meeting. You're talking. I'm guessing the question is the Moravision camera itself, not the one mounted onto an existing microscope. There's a bit of a difference here. The Moravision itself, meaning that there's no microscope It's a camera that sits on top of the patient's chair, and the camera projects onto a monitor, kind of similar to the one I showed, positioned kind of on the wall or on the TV. And the clinician looks at the monitor for the whole procedure. That's usually done in 3-dimension, meaning you're using 3D glasses, so you see in 3-dimension to increase the depth of field. I haven't tried it with Navident. The thinking here that it would mean that the setup might be more simple because more vision is already on a screen. So all you do is you do like I just did on the setup with the TV monitor, is you either place a monitor beside the More Vision monitor and you look at the two, or you could do a picture-in-picture type of setup where you have the Navident feedback in a small portion of the More Vision screen. Now, there's a couple issues here. Number one is there's actually a large percentage of the population that actually cannot sustain looking in 3D with 3D glasses. For whatever reason, doesn't work with their eyes, doesn't work with their brain. They just can't. Creates all kinds of issues, motion sickness or depth field issues. So that's number one. So there may be a limitation here with More Vision that the microscope is not an issue. Number two is the More Vision. What you see with More Vision appears in 3-dimension. Unless Navident can somehow project Navident visual feedback in 3-dimension too, then you have 3D glasses looking at 3-dimension, just like 2-dimension, and you're trying to go in back and forth. I don't know what the effect of that would be. I don't know if that would, again, mess up with the eye, or if it would just not be possible. So this is my understanding. I would love to try the setup with More Vision. Hope it answers your question, Nishan.